Okay, at the midpoint of our paramedic course, we wanted to kind of review some of the things that you've already learned to this point. And if there were to be a formative assessment at the midway point, midterm exam, uh, this would be some of the content that would be on there. So it seemed like a reasonable thing for us to do a very quick, high speed, fast talking review of what we've probably learned. It's amazing how far you've come. There's a lot further for us to go, but this is pretty foundational and important stuff. So we've learned about minute volume. We know that that's the amount of air you move in and out within a minute, which would be your breathing rate times your tidal volume. And that's kind of similar to cardiac output, the amount of blood that's moved in a minute, which would be your heart rate times the stroke volume with each beat. And those are kind of key foundational general A&P concepts. Metabolism, certainly another one of those. Basically, aerobic metabolism takes oxygen and glucose, it burns it, it makes energy, and the exhaust from that, the smoke from that, is carbon dioxide, CO2. So that's where CO2 comes from, and then we use circulation, the perfusion, the circulatory system to move that exhaust back to the lungs where it is ventilated away. You can use capnography to measure what's going on in those three processes, metabolism, perfusion, and ventilation. But really, as long as metabolism's working right and perfusion is adequate, then we tend to use capnography to measure ventilation alone. But the other two have to be in place. The overall goal, of course, is to oxygenate. We've got to get oxygen in and get it moved to the cells. So that involves ventilation, bringing in oxygen from an environment where there's sufficient O2, and then getting it moved to those cells. That's kind of a general A&P recap. We've learned a lot about airway management. We've learned about curved blades and straight blades. We know that curved blade tips go in the vallecula, straight blade tips manage the epiglottis directly. There's kind of a trade-off there, where with that curved blade you get excellent tongue control, but you lose some direct epiglottic control. However, with the straight blades, you lose a lot of tongue control in exchange for very direct control of the epiglottis. We talked about Cormack-Lehane grades. That was a way for us to document what we saw as well as to make determinations on how to manage it. A grade 3 view was where we could only see the epiglottis. We couldn't see any of the glottic opening, and we've decided that a bougie is our best choice to feel our way where we can't see, hoping that we can feel those tracheal rings, feel a hold up at some point, either the carina or shortly past that, where that bougie won't be able to be inserted indefinitely, and that will say, well, we're definitely in the airway tree as opposed to down the esophagus where there would be no end. And so the Cormack-Lehane grades helped us manage that. We talked about pediatric tube sizes, where we would use a chart or the pediatric patient's little finger. That pediatric tubes come in cuffed and uncuffed. And if you have an uncuffed pediatric tube, that will work for you because the narrowest part of the pediatric airway is distal to the glottic opening, whereas in the adult, the narrowest part is at the glottic opening. We talked about blade choices for pediatrics, where that straight blade is probably a better choice because the pediatric epiglottis, especially to little kids, 2 years and younger, the pediatric epiglottis is omega-shaped, U-shaped, horseshoe-shaped, so to speak. It's longer, it's floppier, it's harder to manage. Plus, it is more anterior and more superior, and so what you're really looking for is a straight blade to manage those issues, that direct epiglottic control from the straight blade, as well as the anatomic differences. As far as tube sizes go in general, again, we're probably using little finger of the patient, whether adult or peds. And in the pediatric setting, you're using a chart. In the adult setting, you're probably using your judgment. Most full-size adult males are going to take a 7.5 to 8, and females 6 to 7. Your insertion depth there is, when you can visualize, you want to place it just past the cords. But in the case where you can't visualize, like a grade 3, where you're using a bougie to feel your way, you're going to about 3 times the correctly sized ET tube, and that is to the teeth, not to the tube holder. Bougies and stylets are both options to make your tube stiffer so you can keep the form and get it where you want it to go. We prefer bougies because it allows you to manage a grade 3 while you're in there. Some services will not have bougies or insist on a stylet. If you're going to use a stylet, you want it to be straight to the cuff and then at a 30-degree bend. More airway stuff. Spinal motion restricted intubation is more difficult because you can't get into that sniffing position. Never, never, never try to tube somebody with a collar in place. Always loosen the collar. Have somebody hold spinal motion restriction manually. Again, you can't get in that good sniffing position. More likely to have a worse view, a grade 3 or a grade 4 view. Digital intubation, rarely used, basically using your finger as a straight blade to pick up the epiglottis, your long finger to pick up the epiglottis. And of course, huge risk of trauma to your fingers from the patient biting, so the patient's got to be very unresponsive, and in my view, they've got to be in pretty much cardiac arrest. Nasal intubation, really not used very much anymore. Possibly you might find a use for it if you're going to. You want a BAM whistle so you can time that patient's expiration. You can hear them breathing because you want to insert on inhalation, and you want an endotrol tube, a tube with a trigger on the end where you can direct that tip because you're not going to be able to get in the normal positions and do the excessive head and neck manipulation that you want. So you want a BAM and you want an endotrol. Face-to-face, don't just pigeonhole that as for restricted access intubation like in a rescue scenario. You may use that in a regular code if you want. I find it a little weird because my hands are doing opposite things. My right hand is holding a laryngoscope, my left hand's throwing tubes. That's a little bit different, so hands are in a different spot. The salt airway we think fits in. If you have it at your service, it fits in as a plan B. When you're not able to do direct oral intubation, either with a DL scope or a VL scope, and you have to move on to a blind technique, the blind intubation with the salt we think is a better plan than other blind things. The insertion steps are you put the white epiglottic tongue blade in first and bury that pretty good. It's to pick up the epiglottis so that when you insert the salt that you don't bend that epiglottis over. And then you're going to either insert your tube down through the middle of the salt, or you're going to use a bougie to feel your way, and then go ahead and insert the tube over the top of that and probably remove the salt. Okay, moving on to cardiology. Electrical induction system is a major part of what we talked about. Why do we even have one? In order to synchronize the atria and the ventricles, we want the atria to contract and do a bit of a stretch, the atrial kick. Use Starling's law that says that if we can stretch that ventricle, we can get more pump from that ventricle. And so up to a point, stretching is good of the ventricle. That's the Starling theory. And so the electrical induction system lets us do that by letting the atria contract, stretch that ventricle. So we need a little bit of time, need a little pause in there. And that pause occurs during the PR segment, and it is because the AV node allows that pause to happen. So that's one of the big roles of the AV node, is to allow the pause for the atrial kick. We talked about the wiring diagram to where the sympathetic nervous system is wired in, innervates the SA node, the AV node, and the Purkinje's, whereas the parasympathetic nervous system only innervates the SA node and the AV node, nothing below the AV node, nothing in the AV junction south of the node, and nothing down in the ventricles. So if we're wanting to do something with the parasympathetic system, it's not going to affect the ventricles. So those are big concepts there. Again, the role of the AV node, two really important things. Yes, it's a backup pacemaker, but that's not what's really important. What's really important is that it allows the pause for the atria to stretch the ventricles. And the second thing is that it is protective of the ventricles. When the atria are fibrillating, when there's atrial chaos, the AV node keeps that from extending to the ventricles and creating ventricular chaos. We talked about AV dissociation. That's when the atria are doing their thing and the ventricles are doing their own thing, and those two things are not coordinated. In other words, the electrical conduction system is not helping us any because we've got independent functioning from the atria from the ventricle. AV dissociation we see typically in two cases, one in third degree, complete heart block, third degree AV block, and the other time it shows up is in VTAC. Are there P waves in VTAC? Yes, there can be P waves in VTAC, but if they're there, they must be dissociated. So all this is just stuff that we had talked about in that section on cardiology. We talked about waves. We know what the P wave represents, what the T wave represents, what the QRS represents in terms of depolarization and repolarization. We know that segments are spaces between waves, like the PR segment and the ST segment. And we know that intervals include one or more waves along with a segment. So the PR interval includes the P wave and the PR segment. So it's from the start of the P to the start of the QRS. And what's happening mechanically during that time is that the atria are contracting and stretching the ventricles. And then when the QRS happens, that is ventricular depolarization, which also represents what we hope is ventricular contraction. And then there's a period of reset and repolarization. That's shown by the T wave. So the QT interval would tell us that there is ventricular depolarization and repolarization occurring during the QT interval. We talked about EKG paper in terms of 40 milliseconds for a little box. There's 5 little boxes in a big box, so each of them is, big boxes is 200 milliseconds, which is 1/5 of a second, so you need 5 big boxes for a second. You're going to need, for a 6-second strip, you would need 30 big boxes. A 6-second strip's nice because you count up the number of QRS complexes and multiply by 10 on your 6-second strip, which gives you the patient's heart rate. We also talked about how a 12 lead is a 10-second strip. It's 4 segments of 2.5 seconds. So then for rate on a 12 lead, you just count the complexes across in that 10-second strip multiplied by 6. We talked about the EKG leads as being more camera views. Unfortunately, lead sounds like a wire. So you put 10 wires on, but you get 10 views out of that. So our metaphor is that it's like a security camera system where you can see some areas pretty well. We talked about how there's no camera directly on the posterior left ventricular wall, and there's no camera directly on the right ventricle in any case. But you can move wires around. You can do a V4R, where you take V4 from its spot in the 5th intercostal midclavicular line on the left side and move it to the 5th intercostal midclavicular line on the right side. You can take V6 from its spot in the 5th intercostal mid-axillary line and move it around to the mid-scapular line posteriorly and just use that wire and look at V6. So really, when you do your normal 12 leads, 12 views, you may want an additional 2 views. You need to move a couple wires and run the EKG again. And we'll talk more in the second half of the course about why that is and when you want to do that. But we tried to install right here early on at least how you do it. And I think that'll put us ahead of the game. I'm very comfortable that we are where we need to be. And if you guys know what you're supposed to know and can prove it to us by halftime here, then we're going to be in great shape moving forward. We just got into AV blocks here toward halftime. And the key things there were to march out the P's. If you'll march out the P's, you won't get fooled by missing a non-conducted PAC and thinking that it's a second-degree block of some type. The PRI is what matters as you're trying to differentiate between second-degree type 1 and type 2. The PRI is changing. It's getting longer in second-degree type 1. It is staying the same in second-degree type 2. We talked about how type 1 also is called Winkie-Bach and Mobitz 1. Type 2 is also called Mobitz 2. We sure wish they'd stick with one name, but nobody seems to want to do that. We talked about conduction ratios, meaning the number of P waves per QRS. And when you have more P's than QRS's, you have dropped beats. And so are those dropped beats non-conducted PACs, in which case that beat came early and the P wave looked different, or is it a second-degree AV block of some type? We talked about AV dissociation again in the context of that, especially with complete heart block. We talked about the causes of conduction system problems. Whether it's AV blocks or bundle branch blocks, it's a conduction system problem. And the causes are age, old age, disease, medications they're taking can affect that, street drugs that they use can affect conduction system problems. They may have electrolyte disturbances, but ischemia is the big one. So when you see conduction system defects, you should double check to see if there is ischemia, because we might be able to manage that in some way. And so we also talked about with AV blocks that the analysis of the rhythm is based on the P waves and the PRs, but the treatment is based on the ventricular rate. Said another way, it doesn't really matter if it's second degree type 2 or complete heart block or second degree type 1 or high grade AV block or second degree 2 to 1. Whatever it is whatever it is. If the ventricular rate is 50 or 60 and cardiac output is up and perfusion is maintained, we're not having to intervene emergently. So then it becomes an analysis issue. On the other hand, if the heart rate is 20 and the blood pressure is 80, it doesn't really matter what the rhythm is, with one small caveat that we'll deal with in the second half in the case O and case P. We'll talk about when atropine will work on which heart blocks and which it won't. But for the most part, generically, the ACLS poster on the wall doesn't have anything to do about rhythm interpretation. It's all about, is perfusion happening? So we made that point right here toward the last. Bundle branch blocks we talked about. The issue there is a conduction system defect, the same 5 causes. It's a bundle branch block is one of 5 things that will make a QRS wide. When you see a wide QRS, it's either a bundle branch block, or it came out of the ventricles, or it was was conducted to the ventricles via an accessory pathway. I kind of stumbled on that. Let me try it again. 5 causes of a wide QRS. It came out of the ventricles, as in a PVC or VTAC, radioventricular rhythm. Or it was aberrantly conducted to the ventricles, bundle branch block. Or it took a bypass track, a short circuit, an accessory pathway to the ventricles. Why is the QRS wide with an accessory pathway? Why is the QRS wide with a bundle branch block? It's because the impulse comes down and excites one ventricle, and the impulse goes from cell to cell to cell to cell to cell across to the other ventricle. Instead of going down the main electrical pathway, which is fast and has the ventricles both depolarized at the same time, in the accessory pathway or the bundle branch block, the main pathway is blocked. The two they don't get excited at the same time, so the excitation wave goes from cell to cell to cell across, and that is much slower than going down the fast track. So again, bundle branch block, same causes as AV block. One of the things that makes QRS wide, and the reason that it is wide is that there's cell-to-cell conduction. Accessory pathways, that is when there is a short circuit wire that has grown in, or you were born with, that bypasses bypasses the AV node. So the AV node functions are no longer in place. Number one, the AV node is no longer able to provide that pause to allow for ventricular stretching, for atrial kick. The second thing is that there's no more protection of the ventricles from atrial chaos. So accessory pathways are bad because they bypass the AV node and then therefore take out the AV node's functions. The big risk there is when you have atrial fib, so atrial chaos, and you have a bypass tract. The most common bypass tract disease is Wolff-Parkinson-White, WPW. So what you've got there is atrial chaos running down that bypass tract, bypassing the protective mechanism of the AV node, and turning into ventricular chaos, and that's crazy. 3 signs of an accessory pathway. So we have a short PRI, because the PRI is showing us when the atria are contracting, there's a pause that's created in the AV node. So if you're bypassing the AV node, you're not going to have that normal PRI. So short PRI, wide QRS, because one of the ventricles gets the impulse before the other one, and then it goes cell to cell to cell. So short PRI, wide QRS, and then the delta wave is that particularly specific slurred upstroke on the QRS. So you have a P wave, and then your PRI is very short, if even visible, and the QRS kind of slurs up and starts from there. So delta wave, short PRI, wide QRS, that's the 3 things in accessory pathway. We talked about atrial fib, about how there is no atrial kick, so you're going to lose some cardiac output, probably 10 or 15% loss in stroke volume just based on that. We talked about how there's no regularly definable P waves in atrial fib. In atrial flutter, there are waves that we like to call P waves, but they're technically called flutter waves, a very sawtooth pattern. The problem with atrial fib and atrial flutter is not that the rhythm that they're in, there's no city ordinance against atrial fib or atrial flutter. Lots of people have atrial fib. The problem is the rate. So we're trying to control rate, and that's a key takeaway even before we start managing tachycardias, is that we're not trying to convert them out of atrial fib or flutter. We're trying to control the rate that they're in. Talked about ectopic beats, PACs, PJCs, PVCs. PACs, the beat comes early and the P wave looks different. In a PJC, or in a junctional rhythm, the P wave may be before, it may be during, or it may be after the QRS. So there may be no visible P wave because it occurred during the QRS, or it could be before the QRS or right after the QRS. Either way, it should be upside down because the impulse is starting in the junction and going both north and south. It's going north into the atria, and so it's going to be flipped over, and it's going south and exciting the ventricles. PVCs should not have P waves that are causing them. If there's a P wave around a PVC, it's going to be dissociated. So P waves should be wide, they should be early, and they should not have PVCs should be wide, should be early, and should not have P waves with them. 2 PVCs in a row is called a couplet, 3 in a row is a triplet, 4 in a row is a run of VTAC. That run of VTAC can be non-sustained VTAC if it's up to 30 seconds. Once it goes past 30 seconds, we drop the word non-sustained and we just call it VTAC. VTAC may or may not generate a pulse. That's probably based on the rate. If you think about it, if it's VTAC at 200, there's just not very much time for the ventricle to fill, so there's no blood for it to pump out, so there's no pulse being generated. Whereas if it's running at 130, then there may be a pulse with that. So back to couplets and such, there can also, PVCs and such, there can also be a pattern of trigeminy, bigeminy, quadrigeminy, where you have, in bigeminy, it's a 2-beat pattern. 1 regular beat, 1 extra beat. In trigeminy, 3-beat pattern. 2 regular beats, 1 extra beat. Quadrigeminy would be 3 regular beats, 1 extra beat. If you have 2 extra beats in a row, it's a couplet. 3 is a triplet, etc. As far as ectopics go, we also talked about PACs. When you have very frequent PACs, they are coming from 3 or more foci. So if you have 3 different looking P waves, you have wandering atrial pacemaker, as long as the rate's under 100. Once the rate goes over 100, we change the name to multifocal atrial tach. Little tidbits you might want to know. We also talked about escape rhythm. There's a junctional escape rhythm, which is going to have a narrow complex unless there's a bundle branch block with it. And the rate's going to be in the 40s probably. And the P wave may be before, during, or after the QRS. You may not even have a P wave visible. Either way, if it's before, it should be inverted. If it's after, it should be inverted. An idioventricular rhythm, or a ventricular escape rhythm, is one coming out of the ventricle. So the QRS is going to be wide. There's no P waves, and that rate is usually slower. That rate's in the 20s and 30s. So idioventricular rhythms or ventricular escape rhythms help you escape a funeral, but not for very long because the rate's so slow it can't keep your pressure up, and you get into trouble that way. Meds and fluids. Crystalloids are how we try to replace volume. They take up some space temporarily, but not for very long. So after about the first hour, the liter of saline that you put in, there's about 200 cc's left or so. It has taken up space intravascularly on a temporary basis. The other problem with crystalloids is they don't carry any oxygen, and you got to keep them body temperature or else you're putting your patient at risk for hypothermia because of something you did. Neither saline nor LR have the same pH as body fluids. Now they have the same tonicity, they are isotonic, they have the same salt content, but their pH is much different. In the case of normal body pH, so we'll say 735 or so, and abnormal saline has a pH of 5. So it's like a 30% lower pH. It's 30% more acidic, 1/3 more acid-like than normal body tissue. LR is about halfway in between there, so it's less acidic. Most places are just carrying saline. The other thing we want you to know is that we don't want to give large volumes. Probably up to 2 liters is okay. If you're going to go past 2 liters, you better be talking to somebody. Yes, 20 cc's per kilo is the recommended fluid bolus dose, and you give that over 10 or 15 minutes really as fast as you can. But that turns out to be, in the adult setting, practical measures. You can give about 2 liters, and then you need to be worrying that you're going to make them cool, you're going to screw up their clotting mechanisms, and you're going to jack up their pH. We talked about drip rates. There's 3 kinds of macro sets: a 10 drop, 15 drop, and 20 drop set. Then there's a micro set. Those all come in 60 drops no matter what planet you're on. And then we talked about how to figure out the factor there. The factor is 60 divided by the drip rate. So if I want to know how many drops per minute to run with a 20 drop set, I divide my cc's per hour by 3 because that factor would be 60 divided by 3. So you ought to spend some time making sure you know that stuff, because we're going to poke at it and test it a little bit, and make sure you know your factors. Concentrations. We talked about how to go from micrograms to milligrams and back. Same thing with, and into back and forth on, as well as figuring weight. Sorry about that. And then converting units from micrograms to milligrams, back and forth. We also talked about how to dilute D50, because D50 is very caustic. Should it extravasate, should the vein pop, and you get D50 outside the vascular space, it creates a big deal. So a lot of services are going down to D10 now. How do you get from D50 to D10? Be sure you know how to do that and remember how to do that, and remember why we're trying to do that. We talked a lot about medication dosing and delivery and routes. We talked about buccal administration and oral and IM and IN and ET. And so we remember that ET is not used very much anymore because now we can do IOs, so we can have rapid access. ET administration was used back when we couldn't get IV access. Well, now we can pretty much always get IO access. But ET, you still should know, you can give Narcan, atropine, Versed, not Valium, epinephrine, and lidocaine down the ET tube. That buccal is much faster than oral, so glucose paste should be given buccally. That if you're trying to decide whether to give IN, intranasal, versus IV, the problem with intranasal is you don't know how much they got, or you don't know when they got it, because a lot of it rolls back out of their nose and is inconsistently absorbed. But it sure is faster, and it sure beats nothing if you can't get an IV. Same thing with IM. You get something IM, you're not sure when it's going to work in. You know how much you gave, you just don't know when they're going to get it all. Whereas if IV, you get something IV, you know when they got it and how much they got. We talked about pediatric doses, got the Broslow out, figured out how to give epinephrine in a cardiac arrest to a pediatric patient, because it comes down to worrying about how many cc's you're given. So I'd be sure that I know how to do that. We talked about medication characteristics and gave you a bunch of med cards. And those are action and their indication and their contraindication, their side effect. Make sure you know the definitions of those terms, and you know some of the medications in terms of what their action would be. I would know epinephrine. I would know well, we haven't done atropine yet. I would know epinephrine. I would know anything we used in case A, B, C, D, E, so glucose, glucagon, probably thiamine, glucose paste, oxytocin, magnesium, at least on the OB side. And so if we have used a medicine in a case to this point, then that dosing, or at least that indication, would be fair game for the halftime formative exam. And then terminology. We talked about chronotropes, inotropes, and dromotropes. We talked about parasympathetic and sympathetic, agonist and antagonist, and we mixed all those terms up. We talked about alpha, beta 1, and beta 2, and so we need to make sure you're clear on what a beta 2 adrenergic antagonist does in terms of chronotropy, inotropy, dromotropy, and all those various permutations of that. Anticholinergic, same as parasympathetic antagonist. Know that kind of stuff. All right, wrapping up here. As far as the cases go, I had a chest trauma case where we talked about managing a flail segment is best done with positive pressure ventilation. But the problem is, underlying that is at least a pulmonary contusion, which positive pressure is not going to be a problem for. But if you have a flail segment, you've got 2 or 3 ribs broken in 2 or more places, so there's several broken ends, you probably have a simple pneumo. If the quickest way to make a simple into a tension pneumo is positive pressure, then that's a problem if you're going to be treating a flail that almost certainly has a simple under it. So if you're going to have to treat that flail, then you have to be very, very aware that you may take a simple pneumo and make it into a tension. Once you have a tension, you know that when you have hypotension, either measured as a bad blood pressure or loss of a peripheral pulse, and you have loss of lung sounds, in which case you do a chest needle decompression, second or third intercostal space, mid-clavicular line anteriorly, or you can go in the axilla, fifth or sixth intercostal space, mid-axillary line. Find your spot, poke the rib, go over the rib, get the sharp thing out. You may or may not hear a rush of air, and frequently the little 14 or 10 gauge needles that we have to use will kink off. And we wish we could use something bigger like a PD chest tube, but most of us are stuck with IV caths, and so the need to re-decompress, re-dart is a pretty big deal. Sucking chest wounds, we're going to seal those up on 3 sides because some miracle might happen, and that might actually be a one-way valve, but we're not going to trust the patient's life on that. So a 3-sided dressing or a commercially applied dressing like an Asherman or a SAM works pretty good. Hypovolemic shock, we talked about the signs of that being altered mental status, cool, pale, clammy skin, tachycardia, tachypnea, and eventually a loss of peripheral pulse or measured hypotension, but that's late. And the treatment being lay them down, keep them warm, give them lots of O2, control external bleeding, and move fast. And then we add on the ALS side, we add some fluid therapy, which we already talked about in this review. Altered mental status, many causes of that. We talked about AEI, TIPS. There's a whole bunch of them. Hypoxia, hypoperfusion, both can cause altered mental status, seizures, and strokes, and all kinds of things. And so the overall takeaway from the flow chart there is manage circulation, ventilation, and oxygenation, and then do investigation. Down on the seizures and strokes line, many causes of seizures. Most of them around here are seizure disorders, but there are others. We always want to check sugars. We always want to check body temperatures. We always want to check for hypoperfusion and hypoxia. Cincinnati Prehospital Stroke Scale is an imperfect tool. Includes facial droop, slurred speech, one-sided weakness that's not particularly sensitive, not going to pick up on those posterior strokes. So then there's weak and dizzy and other vague neurosigns. But at least on the interior strokes, you do a stroke scale, and you also better check for mimics, better check for Bell's palsy. Bell's palsy can look like a stroke, but they're not going to have that one-sided weakness. And then check that glucose level, because hypoglycemia can show up looking just like a stroke, I promise you. As far as intracranial bleeds, the usual story on an epidural, at least in terms of scenario builders, is that it comes on fast, may have had a loss of consciousness, and then they woke up and they were lucid. They had a lucid interval. Then they started to decompensate pretty rapidly. It's an arterial bleed, frequently struck on the temporal side of the head, so you have a very thin bone there with an artery right underneath of it. It's an arterial bleed, so epidural arterial bleed. Subdurals, that's a sneaky one. That is a venous bleed. It's a slower bleed. It can be occurring and causing problems days, many days after the trauma, so the fall or the trauma may not even be all that obvious that caused it, though they usually are traumatically caused. The subarachnoid is more likely non-trauma. It's more likely a blown aneurysm. They have a thunderclap headache, so a sudden, worst headache of their life comes on. It is worst at its start, and the patient may have some meningeal signs, meaning they have nuchal rigidity. Their neck is stiff. They have a hard time looking all the way up, looking all the way down, and they're photophobic in many cases, and so just worry about all that stuff. Cushing's triad shows you have severely elevated intracranial pressure. The triad is hypertension, because the pressure needs to be up systemically in order to force blood into the cranium. There's more friction loss going into the cranium. And then that causes a reflex bradycardia. And then the first sign of pressure that's significant enough to push the brain out the foramen magnum, herniation, is when you get pressure on the brainstem area, the pons and the medulla. So you have funky breathing patterns because that pressure is occurring on the brainstem where breathing patterns are regulated. So Cushing's triad is hypertension, bradycardia, and abnormal breathing patterns. That indicates impending or actual herniations occurring. It's a big deal, and you would need to step in and do controlled hyperventilation. the patient really needs to have their head darted more or less, really need that pressure relieved. You can't do that in the field. There may be some role for osmotic diuretics in that case with mannitol. Some services carry those. Hypertonic saline may be used in some places or in the future. Then the last thing, very last thing, is stridor and wheezing. They're both high-pitched musical sounds. They are hard to differentiate from each other. Yes, you can say stridor is more likely on inspiration, but wheezes can be on inspiration. So what we're saying is location, location, location. When you hear a high-pitched sound with auscultation, you need to verify where it's loudest. And if it is loudest over the throat, over the airway, then you have upper airway swelling, and that gets treated with racemic epinephrine, a topical application of vasoconstrictor, trying to shrink that tissue and open up some space, and you may have to intubate. You may be the only one that can intubate. By the time the swelling progresses and they get to the ER, they may have to be criped. So it may be early airway intervention there. Whereas wheezes are a lower airway obstruction. And in the second half of the course, we start off with case L, which is respiratory. We talk a lot about wheezes, but wheezes are coming from a bronchial obstruction, and that is either a bronchial constriction or mucus, excess mucus, or inflammation. It's one of the three or two of the three or all of the three to one degree or another. That's treated with albuterol, bronchodilators, parasympathetic antagonist as an ipratropium, or a sympathetic antagonist, a beta-2 selective agonist as in albuterol. Those are mixed together in duoneb. That's pretty cool because duoneb allows you to have the fast-acting albuterol, but it wears off quicker, but you have the slower onset but longer acting ipratropium, so you get both sides of the coin, and you can cover yourself pretty well there. But that's really kind of case L stuff. What I want you to be sure you know as a follow-up to case K is that stridor and wheezing come from different places and they're treated in different ways. So that is a high-speed, somewhat out-of-control review of what we've done in the first half, what we think are the key points, and we think they're so key that we're probably going to check them on a formative assessment. Good luck with that.